few remarks. Cynthia? Okay, maybe Cynthia hasn't joined us quite yet. We'll pick her up when she joins the call. As our webinar series continues to evolve, we at the HHQI continue to look for best practices around some of the drivers that contribute to avoidable hospital readmissions. Certainly one of these drivers is inadequate and inefficient communication across care settings. The title for today's presentation, Conversations Across the Discharge Divide, Evidence-Based Communication Among Patients, Hospital-Based Providers, and Community Healthcare Resources, fits sort of one of these drivers that we've certainly identified. We're pleased to have with us today 3 members from Northwestern University. Before outlining the sequence of our presentations today, I'd like to say a special thank you to Dr. Mark Williams, who's a professor and chief at the Division of Hospital Medicine at Northwestern University Feinberg School of Medicine. Mark's role on our physician advisory group has been greatly appreciated, and he contributes or continues to be a very dedicated supporter for improving transitions across all care settings and is involved in many efforts around this topic of avoidable hospital readmissions. So thank you again, Mark, for all of your help. Our presentation today will be broken down in the following manner. First, Dr. Luke Hansen, an instructor at the Feinberg School of Medicine at Northwestern, will speak from the hospital perspective, including sharing information on Project Boost and healthcare reform and some of what is to come from this healthcare reform regarding hospitals and other care settings. After Dr. Hansen's presentation, Dr. Rob Young, who's a postdoctoral fellow, Institute of Health Care Studies, clinical instructor, Division of Hospital Medicine at the Feinberg School of Medicine, will discuss communication issues encountered with patients who transition from the hospital to a skilled nursing facility and some ways to improve this overall process. After Dr. Young's presentation, Jessica Pawlowski, a licensed clinical social worker who's the manager in the Department of Case Management at Northwestern Memorial Hospital, will discuss the current process flow regarding involving home health and the role moving forward for case managers serving as a critical communication linkage. After Jessica's talk, Dr. Hansen will come back and share a couple of thoughts on the future of healthcare models. Following the presentations from our speakers, we will have some time for questions. As we've done in the past, we'd like you to, as the presentation is going, to generate your questions. Please forward them to hhqi@wvmi.org. Again, hhqi@wvmi.org. And we'll utilize this format after the presentation to handle a Q&A time period. Without further delay, we'll get started, and I'd like to turn the presentation at this point over to Dr. Luke Hansen. Luke?
Thanks a lot, David. And thank you to everybody that's joined us. I hope that we can provide you some useful information and hopefully some information that you can apply to your practice. As David said, I'm going to be speaking, I'm going to be speaking about principally the transition from hospital to home, looking at the risks that have been identified and some of the interventions that have been tested, specifically interventions that are relevant to home health potentially. After I speak, Rob will be focusing more in on transitions to and from skilled nursing or extended care, and then Jessica will bring the home care perspective and sort of our institutional perspective here at Northwestern Memorial. So to start, I'd like to put all this in a little bit of broader policy context. I've added a picture here, an archival image of Lyndon Johnson signing the Medicare legislation back in 1965, and he's signing off on the first beneficiary card, which was given to Harry Truman, who's sitting next to him there in the picture. And I include this because I think it really is a watershed moment, and people with much more experience and perspective than I do have made this observation many, many times, that Medicare really changed how we deliver health care in the country and how we pay for it, and it set up a system of incentives that we all now operate under. For that reason and other reasons, including technological evolution and changes in the makeup of the population, we've seen healthcare spending grow as a percentage of our gross domestic product year over year, almost without exception, since the 1960s, and it has continued to grow into the future. With that in mind, we need to look for ways that we can reduce cost, control cost, but at the same time improve quality. We don't want to get in a situation where we're reducing cost and reducing quality at the same time. Now that potential sweet spot came on the radar in the form of the issue of rehospitalization. This article, written by my mentor Mark Williams, as well as Eric Coleman and Steve Jenks, really highlighted that issue and brought it to the fore in the national conversation. Now, the important findings of that article are that 1 in 5 patients were rehospitalized within 30 days of admission among the Medicare fee-for-service population. A couple other important points to keep in mind, that half of those patients hadn't seen an outpatient doctor before they were rehospitalized. In addition, 70% of surgical readmissions, so patients that were initially admitted for a surgical procedure, of those patients that were initially admitted for a surgical procedure, 70% were readmitted for a medical condition. So it wasn't surgical complications as much as medical complications. And then lastly, the dollar figure that they placed on these rehospitalizations was $17.4 billion. And keeping in mind that's just among the Medicare fee-for-service population. So the overall figure for the country is probably much higher. Now that figure and that evidence was not missed by policymakers, and so when they crafted the Affordable Care Act, they put in specific legislation to alter the incentives in a way that encourages hospitals to control the problem of avoidable readmission by adjusting payments beginning in 2015. In 2013, and then it will increase to 3% of overall Medicare payments by 2015. So with that kind of background, we need to spend some time figuring out what's going wrong around discharges and then what we can do to address that. So a couple slides about what we know are the weaknesses in the discharge process. Both these articles were written by Alan Forrester, and they do a good job of highlighting what problems exist at the time of discharge. In this first article, he found that almost 20% of patients had a post-discharge adverse event, and that a full third of those were preventable and another third were ameliorable, which is to say that only a third were completely untouchable in terms of changing outcomes. And then in this follow-up article, he found a similar statistic, 23% of patients had a post-discharge adverse event. And what I really want to highlight here is that almost 3/4 of those were found to be medication-related. So if you were looking for a place with potentially high return on an investment to reduce readmission, that medication-related adverse event statistic is very compelling. So in addition to those issues that have sort of been witnessed in terms of outcomes, there's this issue of process and communication. I think an excellent review of this is Sunil Kripalani's systematic review in JAMA from 2007, which identified, among other things, these points. That direct communication from provider to provider around discharge occurred in 20% or less of the time in the studies that they looked at. Indirect communication using a discharge summary was also inadequate. The availability in the first week post-discharge was only 12 to 34%. And in our institutional experience here at Northwestern, the majority of our rehospitalizations are going to occur within the first 2 weeks. So if you're not getting the discharge summary out the door in that time period, there's really little hope that a ambulatory provider will be able to effectively respond to any sort of issues that recur following a hospitalization, not knowing what was done during the hospitalization. And when people get discharge summaries, they often lack things that would be considered important. The results of tests that were performed in the hospital, what occurred in the course of the hospitalization, what medications the patient was on when they were discharged, and what further tests needed to be followed up. So with that in mind, with that sort of background, I want to spend some time talking about what's been looked at as ways to reduce avoidable rehospitalization through building communication both while a patient's still in the hospital and then after a patient is discharged. So looking up front here, before discharge, patient education, discharge planning, and med reconciliation. So that first point, patient education, you know, communication, I would put under that umbrella teaching, and the idea that we may not always do the best discharge teaching. I'll speak in a little bit about Project Boost, something that I've been working on as part of a national group to reduce avoidable rehospitalization. Project Boost really advocates a process called Teach Back, where you deliver information to the patient and then you confirm with them by them restating it back to you in their own words the effectiveness of your teaching. And that sort of an emphasis on patient education has been tested and has been shown to be effective. Discharge planning, I think the home care audience is aware that communication between discharge planners within a hospital and various caregivers that are going to take care of a patient after hospitalization is important. Interventions that have tried to improve that process have been shown to be effective. And then the last point, medication reconciliation. Not really a communication point necessarily, outside of that teaching, the teaching context that I spoke of earlier, but given that so many adverse events post-discharge are related to medicines, it's important to keep that in mind as we think about how we can better handle discharges to avoid rehospitalization. And then on the other side, interventions after discharge, things like a follow-up phone call to build communication. That would be the hospital initiating a call out to a patient. There's also sort of a partner to that, the patient-initiated phone call, like a hotline mechanism. Timely PCP evaluation, so that's that near follow-up, keeping in mind that so many hospitalizations occur directly in the week or two after discharge. And then lastly, home visit, something that I think, again, the home care audience probably is aware of the value of potentially. I'd like to drill down a little bit into some of these interventions. You know, I'm particularly interested in relaying the importance of interventions both in these two before and after categories, but also in other categories that seem to facilitate communication across that gap there. It's not things that aren't a before intervention strictly or an after intervention, but that really carry information across. And the things I want to highlight in that crossing, bridging category are things like patient-centered discharge instructions, which facilitate communication by being very sensitive to patient health literacy. A great example of that is Project RED, Brian Jack's work. And then transition coaches or nurse discharge advocates, the work of Eric Coleman and the Care Transitions Intervention, as well as the work of Mary Naylor, have used these figures, these clinical figures to facilitate information transfer and improve communication. So I spoke before of home visits. I've listed here several studies that looked at home visits and their effectiveness. I include them in the study in the slide set now so that at your leisure you can go back and look them up and see the really unique characteristics of each one of these, because there is a lot of heterogeneity. But for the purpose of this talk, I want to just point out the absolute risk reduction. Now the first two studies, -2, -10, that means that they were not associated with an improvement. There was a non-significant trend towards higher readmission rates. Now, you know, given that most of this data is non-significant, it's hard to say that for sure there was a push, an effect of the study intervention. But you can see that the take-home is that there is not a lot of significant, statistically significant data supporting home visits. Now that I don't think is a result of the ineffectiveness of home visits. I think it's that these are very hard things to study. If you want an example of a really well-done study, I would look up this last piece of work by Eric Coleman, where he details the effect of the Care Transitions Intervention. Nurse discharge advocates, or transition coaches, as Eric Coleman calls them, are another, I think, important provider role that we'll be seeing more and more of in the future, and it's a space that home care is sort of partially on the way to doing already, so I bring it up for you now. As you can see, again, there are several non-significant findings, but there are, again, these significant findings by Coleman and his colleagues. that I think point us in a direction that we should pay attention to. So, part of the reason that I'm on the call is to talk a little bit about Project Boost. That's an initiative that I've been doing analysis for over a year now. Project Boost was funded by the Hartford Foundation several years ago now as an effort to come up with an evidence-based toolkit that could be widely disseminated nationally to reduce rehospitalization. And this map here is of the current active Boost sites. I'll also point out at the bottom of the slide is the web address, the URL for Project Boost. And the tools that I'm going to talk about over the next couple of slides are available there. So what is Boost? Well, the overall intervention involves technical support. There's a mentorship component where hospitals are physically visited, and then there are teleconferences monthly by trained mentors. People who have experience in the evidence base around rehospitalization, as well as experience in organizational change. There are teleconferences that are more didactic. There are educational opportunities, both through webinars and newsletters. And then we have a Teach-Back DVD that sort of goes through the process of how to implement Teach-Back and how to actually do it at the bedside. A second component that I think is really valuable is the peer support network. Each Boost site, each hospital that's not a Boost site, as they try to change their discharge process and their care transitions process, is going to have to struggle with its own unique climate and context, but that said, there are benefits to understanding what other sites have done, and so we've put together some tools to allow that. And then lastly, the Boost Toolkit, and I want to highlight that this is freely available. You can track it down on the SHM website at that URL that I had up on the last slide. The Boost Toolkit brings together what we think is kind of the best evidence for what hospitals can do to improve transitions. And I'm just going to highlight a couple of those tools now. One is the 7P risk assessment. So that's a series of P words that we feel are kind of identifiers of high-risk patients. And that's something you can do when someone's admitted to the hospital. I suppose it's something you could do when someone comes into your care as a home care provider. When they have these things, that makes them someone who you may want to pay special attention to in regards to their risk of rehospitalization. And secondly, tools that can be implemented as someone approaches discharge from the hospital to facilitate safe discharge. The gap assessment takes a look at the home environment, something that I know that you all do, and looks for risks there. And then the discharge checklist is like many checklists that are becoming common in clinical settings. It's a short list of things that we think are really essential to ensuring safe discharge. The third item here is tools that support patient and family caregiver preparation, things that help patients and families to really become good advocates and very effective advocates for their care. And then lastly, discharge summary communication is kind of a general concept. We really emphasize the importance of getting that discharge summary to the ambulatory provider so that they can make educated decisions based on what has gone on during the hospitalization as they take care of a patient in the post-discharge setting. With that, I'm going to pass over the control of the presentation to Rob, and I appreciate your listening. Look forward to your questions when we're done with the webinar.
Great. Let's see. Okay. 1 second. Hello?
All yours, Rob.
I don't think we can hear Rob. Hang on just a moment. I think he has computer problems. Jessica, I'm actually going to ask you to present this time, and I'm going to have to ask Rob to call back in. For some reason, he's been disconnected. Could we go ahead with your presentation first? Okay, sorry. So you should have the presenter privileges, Jessica.
Okay, thank you. Okay, so I'm Jessica Seuss-Pulowski, and I'm one of the managers in the Department of Case Management at Northwestern Memorial Hospital, and I'm honored to be included in this webinar, so thank you very much. I just wanted to really present my portion of this, speaking more to the home health agencies and healthcare providers who I hope are in the audience and listening to this presentation today. I wanted to provide a more concrete day-to-day application of some of the content that Luke already referred to regarding healthcare reform, and we will briefly assess the current case management practice in the context of healthcare reform, contrast current state practice with future state practice, and discuss the role of home health agencies in this future state practice. And, you know, first of all, I just wanted to acknowledge that within all hospitals, we have various names and titles for the different disciplines. We have, whether it's the care coordinator or the case facilitator or the patient navigator, the patient care coordinator, all of these titles represent sort of the same type of discipline, sort of the same type of role. And further, the kind of departments that oversee these different disciplines could be case management or the social work department or the Department of Discharge Planning. And I think that the point here is that there is no standardized process or standardized role. Every hospital, every system is different, and it can be a process of navigating exactly who does what. And I just wanted to validate to the home health care providers out there, the liaisons that take referrals from hospitals and from these various disciplines and departments, that we do an excellent job of making it confusing for you. And so we appreciate the hard work that you do, and we know that it isn't always easy. And then to further complicate things, there are different approaches and models of care coordination within these departments. You have your integrated approach, which is your one-man show type philosophy, and there are pros and cons for that. Of course, you can have one individual who is handling all the communication to the patient and family, all the referrals, all the discharge planning, and you know, oversimplifying things a bit, one of the major pros to that is that it is one point of contact. It can lead to great patient and family satisfaction, not always a lot of fragmentation of care. The con to it, of course, though, is that it can evolve into a very task-oriented type role where maybe perhaps the more psychosocial elements of care coordination get lost, the ability to be able to escalate to the point of resolution with complex discharge plans can get lost as well. So then you have your collaborative model, which has separate disciplines doing different pieces of the discharge planning. So you often have your nurse who is arranging the home care and handling more of the clinical nursing aspect, and then the social worker who might be handling the complex psychosocial aspects. And again, a pro to this is that it's expertise specific. You could have trained specialists actually doing the work that they are trained to do. The con, of course, I believe, is that the more people who are in the mix can complicate things for patients and families, and it could possibly lead to fragmentation of care. And then sort of a subset of the collaborative approach is this Triad model, and that is part of collaborative, but it's really trying to now integrate a third individual, a third discipline, which is a non-professional who handles the task-oriented, concrete aspect of the discharge planning. And what's really great about the Triad approach is that that individual can do all of the facilitating with outside referrals and ensuring that follow-up is complete from the inpatient perspective, but the social worker and nurse are still left to be able to do their trained discipline-specific aspects with the patient. But currently, in the current state of discharge planning, we know that the focus is on the inpatient and our ability to move the patient to the next level of care. It's on moving patients through the continuum. And so what I wanted to offer to you is sort of a very brief overview of what the inpatient process can be. Patient gets admitted. The interdisciplinary team develops a discharge plan. The discharge plan is presented to the patient. From there, barriers are identified. If we say, okay, here's what we've identified as a plan, you're going home with IV antibiotics and you'll need somebody to assist you, and that is the moment that we find out that the patient lives alone and that can't possibly happen. And by the way, I have 6 stairs to enter my home. And so the discharge plan is then revised. We present it again to the patient and we repeat this cycle as necessary. Finally, the discharge plan is secured, the patient is discharged, and from the inpatient world perspective, that's sort of the end of it. And then fast forward 5 days, the patient presents to emergency department, repeat cycle. So I know this is a little bit of a cynical view. Obviously, we do a fantastic job a lot of the times, but we also know that this can be the reality. The intention is not to make a mockery of the process, but we do know that there seems to be quite the cutoff in our current process with ensuring and securing that outpatient follow-up care is happening and not just cut off from the point that that the patients and families are discharged from the inpatient setting. So here would be an example of the current process flow for a home health referral. So in our model, we use the terminology of a care facilitator, which is a nurse. So we have a care facilitator making a referral to the home health agency, and we make the referral to a liaison. The home health liaison reviews the case, accepts the case, then the liaison gives a report to the home nurse, and the liaison could be the individual who, if the time permits, can go meet with the patient while they're still hospitalized. They can be that face to the agency. They can provide pamphlets, starting to build a rapport. But then there is absolutely no continuity with that actual liaison once the patient gets home. Then the main point of contact is the actual in-home nurse. And so there's a fragmentation of care that occurs, perhaps even a breakdown in communication, once the nurse who's actually going into the home follows the patient. And from there, I think it's fair to make some assumptions that the care facilitator and those in the inpatient side make these assumptions that the home health agency will communicate with the primary physician what is happening in the home. And we also sort of follow this perspective that everything is working out well and according to plan once the patient leaves the hospital. And a care facilitator would not, under normal circumstances in our current state, receive any follow-up or updates about a patient in the home setting once they leave the hospital unless something went really awry and new plans have to be made. And that is pretty rare in our current state. And so as our first presenter, Luke, was referring to, healthcare reform is really the driving focus on readmissions right now. And from our perspective, in our experience, we really believe that home health providers will become integral to bridging the gap between our inpatient hospitalization and outpatient follow-up care. So in my research in the home health programs that exist out there right now, we know a lot are emerging. There are many different names to the different programs that exist, but I'm going to use this generic title of, quote, transitions to home. So yes, many other names and titles, but what we know is that they exist. Some organizations are doing a great job of promoting these programs, but from my experience, they're pretty underutilized. The transitions to home programs understand the necessity of addressing the medical home model. And the medical home model is something Luke will briefly speak about at the end of our entire presentation. But essentially is physician-directed coordinated care that should result in higher quality care and outcomes. And the type of quality care and outcomes we hope that would be impacted would be rates of readmission, emergent care rates, patient compliance, and medication management. So what are some of the common features and benefits of these transition to home programs? Well, most of them seem to promise a dedicated case manager for the primary physician practices. So this, I think, would be an excellent way of ensuring effective communication and building strong relationships between that home health agency, that nurse, and the primary physician. Also, they can do medication reconciliation and while the patient is still in-house and provide that to the primary physician prior to the initiation of the home health services. And this can provide really great real-time information to the primary physician regarding the hospitalizations. They also can provide outpatient follow-up appointments, ensure that they're made. They also will ensure that the patient went, and if they didn't, or if there's obstacles or barriers to the patient attending the appointment, which could simply be someone needs to go with the patient or if there's no transportation, but can address all of those issues. And then lastly, and of course I'm summarizing here because there are multiple features that different health agencies offer, but one of the last ones is an ongoing condition and disease management. This type of education that occurs in the home that's provided to the patients with the intention of promoting self-care and empowering the patient and family to manage their own condition and disease from home. So rather than them feeling isolated at home, developing symptoms and not knowing what to do with that information, and so the next logical step is go to the emergency room, the home health nurse, along with the primary care physician, can develop a care plan for the patient and assist them in understanding their symptoms and what to do if you have this symptom, what to do if you have symptom B, C, D, and allow the patient to be empowered in that way. And so within these transition to home programs that we see emerging with home health agencies, we know that they're also doing a fantastic job of trying to cater specialized programs to certain unique populations. Some of them that I'm seeing out there include programs targeted towards high-risk falls, balance training, heart failure, and the heart failure programs is something I want to target and talk about a little bit right now just because we know that it's the #1 diagnosis for hospitalizations in people over 65. We also know that heart failure is one of the diagnoses that will be looked at most closely when healthcare reform, the legislation begins. And so some of the common features that I am seeing with specifically with the heart failure programs include a use of a cardiac nurse in the home, completion of assessment and development of the home care plan with the primary physician, which can happen with the other programs, but they will complete this within 24 hours of the patient's arrival back home, and then will educate the patient on how to use, and this goes back to that patient empowerment and understanding and managing their own condition, is how to use these different monitoring systems. And again, I'm using this phrase, telehealth, but there are various names out there for sort of the same type of program that's established. And essentially what it is a monitoring system that allows the patient to know how to track their own weight, oxygen saturation, heart rate, blood pressure, et cetera. And then that information is provided to the primary physician for ongoing monitoring so the patient can be allowed to stay in the home, again, to not go to the emergency room. And one of the, I think, really interesting tools that have been developed is sort of this traffic light tool that allows the patient to see red light, yellow light, green light. Red light being these are the symptoms that you're experiencing, and stop. Red light, you do not have to go to the emergency room. You do not have to call your physician. These are the things you, the patient, can be empowered to do to manage that symptom. This is what you need to do first. And then goes down through yellow light, green light, and helps the patient to understand with each symptom that they have, what would be the appropriate step to take to understand that. And so all of those things taken into consideration with better utilization of the home health agencies and what they're capable of offering and where we are headed with how we see the care facilitator role evolving in our future state. This is, I think, a revised version of the earlier slide that I offered regarding the process flow for a home health referral. So in this scenario, the care facilitator would make the referral to a home health agency. It still would be the home health liaison that would accept the case for the agency, but it would be the liaison that would facilitate the home progress report with the home nurse who's actually in the home, and including information about outpatient appointment compliance, and would facilitate that information between the patient and the home nurse, the primary care physician, and this communication between inpatient hospitalization and post-hospitalization, this care plan, is less fragmented. That liaison continues to be an important role throughout those crucial 3 to 5 days after hospitalization. The liaison will receive that information and will provide a follow-up report to the care facilitator 3 to 5 days after the patient is discharged from the hospital. The care facilitator, going back to some of those boost principles that Luke referred to, would perform a discharge callback. They would call the patient and effectively ensure that the report that was given by the liaison to the home care company is same as the patient's perspective. We can assess for risk. We can assess that the patient, yes, indeed, followed up with the outpatient appointment. This greater partnership, this, as I see the evolution, will be in an increased involvement with home health agencies, a greater partnership with inpatient care coordination and outpatient services. And so I think that there is a lot of mutual reliance between the inpatient side and what the home health agencies and home health providers will be able to offer. So as we consider the impact to home health agencies in light of healthcare reform, that goes back to a little bit of what we discussed with the medical home philosophy. One of the things that I'd like to know at the end from our listeners is, how many have already implemented programs like this or at least intend to. I think that's something that I would like to open up as a question I'd like to pose back to the audience. So now I believe that Rob is going to speak next about the skilled nursing facility and the partnership with the inpatient facilitation.
Hello? Great. Let's see. Can you hear me?
Yes.
Okay, great. I apologize for the technical difficulties here. My computer had frozen. Okay. So my portion of the call is to just review some of the literature behind skilled nursing facility readmissions as a continuum of what we've discussed already. And as Luke had mentioned, there's been recently a lot of interest in readmissions, but the literature behind readmissions has has been there for quite a while, with one article back in 1984 in the New England Journal of Medicine, where they had realized that they had discovered that about 22% of Medicare patients were readmitted within 60 days. And then there were subsequent articles that had found that these readmissions were potentially preventable anywhere between 34% to 48%. And then more recently, you have the article that Luke had mentioned about that came out from Jenks, Williams, and Coleman describing Medicare readmissions. Now, for skilled nursing facility readmissions, the seminal paper came out back in January of last year, and in this article, Vincent Moore, who's at Brown, looked at Medicare data and looked at the percentage of patients who are being readmitted to hospitals from skilled nursing facilities. And so, in terms of skilled nursing facilities, about 40% of Medicare patients are discharged to some type of post-acute care, either home health agencies, inpatient rehabilitation facilities, skilled nursing facilities, LTACs. About half of these are discharged to SNF. So that's about 26% of hospitalized Medicare enrollees. And what they ended up finding was that there was approximately about 23.5% of the SNF patients were being readmitted in 30 days. And what was also concerning was that through their analysis of 2000 and 2006 data, these numbers are actually rising from 18.2% to 23.5%. And when they went back to estimate the cost of Medicare as to how much these skilled nursing facility readmissions were costing us, it was around $4.34 billion. And so there's also been some past literature looking at preventability, as I mentioned before, and this is actually a slide on data from MedPAC, where they had found that there was significant percentages of patients who are being readmitted for what they consider potentially avoidable conditions, either electrolyte imbalance, congestive heart failure, respiratory infections, urinary tract infections, and sepsis. And in other reports, they actually think that the preventability numbers are probably around 28 to 40% of skilled nursing facility readmissions are avoidable. So what do we know about factors that lead to skilled nursing facility readmissions? There's some literature about facility-related factors in terms of higher nursing staff levels associated with lower numbers of readmissions, the lack of ability of resources at SNFs, such as access to primary care clinicians or clinicians in general, laboratory tests, and certain IV treatments. In addition, another area that's been documented in the literature that contributes to skilled nursing facility readmissions is Medicaid policy. Specifically, there's been one study that looked at state Medicaid bed hold policies and found that if they had fairly generous bed hold policies for their nursing home patients, that there was spillover effect, and it turned out that the skilled nursing facility patients were being readmitted at a higher rate. And then there's also this recognition that because many of the skilled nursing facility beds are located in nursing homes, that they actually share resources with kind of Medicaid funded beds in nursing homes, and so there is an interaction between that. In addition, there's some patient-level factors in terms of functional status, number of emergency room visits prior to hospitalization, and comorbid health conditions. And there are, although we've gone through some of the factors, there's still many factors that still need to be investigated that are thought to be potential factors contributing to skilled nursing home readmissions. These include nursing home litigation risk, the lack of available records. For instance, at skilled nursing facilities, they may only get the photocopy of the last 5 days of a 1-month hospitalization, which really limits the amount of data that's been transferred over for skilled nursing facility providers to use. There's also issues with patient stability, where not as acute care physicians were sending patients over that are truly stable and can be cared for at that setting. There's also issues of omitting palliative care end-of-life discussions for patients who are fairly sick and perhaps warrant palliative care interventions. And then also communication. It's concerning that as these patients going over skilled nursing facilities are fairly sick, in most places there's no phone call to the skilled nursing facility doctor. Everything's kind of transferred in paper, and it's kind of a haphazard way of doing this transfer for a fairly sick patient. So in terms of current interventions, there are quite a few interventions looking at readmissions in general, like BOOST or the IHI programs. There's not a really well-established program looking at skilled nursing, acute care skilled nursing facility transitions at this point. There is a project that the American Medical Directors Association support that's currently ongoing in nursing homes, and that's called the Interact 2 project. And this project is really aimed at decreasing nursing home admissions and thereby decreasing skilled nursing facility readmissions. And they've really concentrated on aspects of communication with the hospital, with family. They have care paths to deal with, for instance, if the patient has a change in status with fever, to figure out what they can do at the nursing facility and what needs to be sent to the hospital, but with good communication. And there's also a focus on advanced care planning too. So our hope here at Northwestern is in terms of skilled nursing facilities, is to eventually try to build pieces that would constitute a bridge between an acute care program like BOOST with something like Interact in the nursing facilities to address the special patient population in terms of its readmissions. So finally, I just wanted to go over the impetus for doing all this. Certainly there's been a lot of talk about ACOs and accountable care organizations. There's also bundling that has been prescribed in the new health legislation. And so according to the new healthcare law, by January 1st of 2003, there should be pilot programs looking at bundling between the acute care and post-acute care episodes. And on the right side is just a graphic showing some modeling that some contractors are doing, looking at how to bundle these payments. And it's fairly easy to think of how they could actually build in penalties for readmissions into this payment system. So I think that's all I wanted to go over. So I think Luke has some more to discuss with us in terms of transitions and the new healthcare legislation.
Yeah, thanks, Rob. I just have one more slide, and Bethany, can you pass that back to me? Thank you. And it's sort of just by way of conclusion. We've talked in each of our presentations about the policy context for care transitions and how we all have the opinion that the landscape may change a lot in the next 5-10 years as incentive structures and actual relationships among locations for care change and evolve. And that's reflected in this final slide. The idea that no longer will there be the same siloing of care locations. We've talked about medical homes, which will be there'll be practices, but there'll be practices with a broader mandate to coordinate care than they used to have, and so there will likely be home services involved in that. Similarly, hospitals with the reimbursement adjustment that they face with high avoidable rehospitalization will also be incentivized to reach out beyond their borders, beyond their walls for the first time, or at least in a way that they haven't been previously. So where does that leave home care? I think that it's worthwhile to imagine a world not so far in the future where where home care is really welcomed into the hospital in a way that it hasn't been before, to start that relationship before a patient's discharged. I think that the discharge coach or the nurse patient advocate role is a good place to look for examples of that. So I think to close, I'd like to just leave that as food for thought, that the models of communication that are dependent on written documents that go from provider to provider may be only a piece of what we have in the future, where it would be my hope we have a lot more opportunity for face-to-face communication, whether that is through a TV screen and an internet connection or literally physically present. The opportunity for longitudinal care to happen in a way that it hasn't before. So with that, I think we'll open up to questions. Thank you for your time, and I hope we can provide you some additional information.
Thanks, Luke, Rob, and Jessica. I think we're ready for the Q&A portion. Again, for those on the call, you can submit your questions to hhqi@wbmi.org. I'm going to turn it over to Shannon. We can get started with questions.
Our first question comes from William, who asks of Dr. Hansen, are all of the Boost tools free for anyone to use?
Yes, I would say they are. You know, there's what I would call the Boost Toolkit is kind of a summary of the best evidence, and those are available through the website in the form of a PDF toolkit book or a booklet that tells you how to well, see, this is where it gets a little bit difficult, because all that can be done. You know, what I think the other offerings of Boost, the online community and the mentorship component give is they really push the Boost implementation team that's at the site to get it done, and that's really hard. You know, I've been involved with several sites over the last year, and as you may know from other quality improvement things you've been involved in, it is hard to sustain effort that is necessary to implement, in some ways, a fundamental change in how hospitals look at rehospitalization and how hospitals look at their responsibility in the post-discharge period. You know, we have done some qualitative research interviewing sites, and they frequently say that that effort of competing quality priorities for a hospital is difficult. Now, that's not something you need the Boost you know, the Boost infrastructure beyond the toolkit to do, but there is a fee. We SHM, Society of Hospital Medicine, does at this point charge a fee for those services. So you know, I think we leave it up to sites to decide how they can best use their internal resources and whether it's worth an investment in the things that are offered in addition to the toolkit.
We have a similar question about Boost that comes from Florida, where Lynn asks, is the website address hospitalmedicine.org/boost? She says she was unable to open the address but would love a copy of the Teach Back DVD.
Let's see. The Teach Back DVD, I don't know if that is on the website. I sort of don't think it is. I'm just doing a little Google search myself. If you Google SHM Boost, SHM space B-O-O-S-T, you get to a landing page for Boost, and then I don't know how many, I suppose a lot of people are on their computers right now. I don't know off the top of my head how to navigate to the toolkit, so I won't spend time looking for it. But it is there, and you can look around for it. And then there's also some case studies that we've put up, kind of telling what some of the STAR sites have been able to do as well. So I hope that helps you find the toolkit.
We have another Boost-related question. This one comes from Gail, who asks, can you tell us a little more about rolling Boost out in a large hospital setting? How do you do this? Achieve staff buy-in, et cetera?
Yeah, it's so at this point there are over 45 sites that have had their kickoff conference and are underway. Actually a lot more than that. There's probably close to 60. And what we've seen generally is that sites start with one unit and they start with one tool. They don't try to do redesign the discharge in one fell swoop, because I think that obviously if you're talking about a 500-bed hospital is a gigantic undertaking. And I think there is some value to be gained from thinking of a individual unit as a laboratory for the larger hospital. So generally that's what sites do. We have smaller sites that just by nature of how small they are, 50 to 100 beds, they roll it out hospital-wide from the beginning. It's also another thing that I would say in terms of rollout is that many of the elements are best rolled out in the setting of an electronic medical record for hospitals that have that. And that is really, that can be a more time-intensive process to build it into the EMR. So what often happens is that the non-EMR dependent things get rolled out first while the building around how to put these tools, integrate these tools into the EMR happens on more of a longer timeline.
Our next question comes from Grace, who asks, do you have more information on the types of adverse events that occurred after hospital discharge? Also the timing post-hospitalization of the adverse events?
I would refer you to those two articles. They really, I just skimmed them, the Alan Forrester articles that were in my presentation. I just skimmed them, but he and his team go into a fair bit of depth on the nature of those events and the causes.
Next, Aaron asks, how can our Patient and Family Advisory Council support or be incorporated in the implementation of a BOOST program in our hospital?
That's a great question. I think that patient health literacy is key. I don't, Jessica, do you have some experience from here about our Patient Family Advisory Council?
We do. I think depending on each hospital, for example, here at Northwestern, we have a very robust patient advisory board who, highly respected and regarded and really engaged. And so the ability to go before the board with ideas, get their ideas, to present them with opportunities for that hospital and then to gain the support from the patient's perspective, I think is integral in any program being developed. So I would say that it would have to be an opportunity to engage whatever advisory board may exist at each hospital level. That's something we do frequently. I think, again, to have that patient perspective as to what's feasible, what they want from that angle has to be incorporated.
We did a quality improvement measurement effort here where we interviewed patients after they were rehospitalized and tried to do some analysis of what was driving that. And that was not through a Patient Family Advisory Council, but obviously engaging patients to deconstruct what falls apart when they go home is key to understanding that. And, it's our hope as researchers in our division that we can help contribute to that in a systematic way so that it doesn't have to be done on a site-by-site basis, because there probably are a lot of transcendent phenomenon that happen across the country as patients go home.
Our next question comes from Laura, who asks, it's interesting to hear about higher skilled nursing facility staff shows lower readmission rates. How does this message get to the administrators and managers who make staffing decisions?
I guess, yeah, I'll take that one. I don't know. I think there's a lot that goes into that, right? There is, Medicare reimbursement, Medicaid reimbursement policies that affect, the resources that you're able to deliver for the patients. Yeah. So yeah, I'm not sure how that, outside of changing regulations and things of that sort, how you could have that transmitted up to the people who make those decisions.
Next, we have a two-part question from Rosemary, who asks first, at your facilities, who is obtaining the new face-to-face documentation requirement? And secondly, for the telehealth, any suggestions on who would pay for this service once the patient no longer qualifies for home health?
Okay, so what was the face-to-face part again?
For the face-to-face part, it says, at your facilities, who is obtaining the new face-to-face documentation requirements?
Luke or
I need a little more background about what part of the process.
Yeah, well, I'm afraid I'm not sure of what
they're referring to.
What requirements what aspect of the care that's referring to. I apologize.
No problem. We'll move on to another question that asks, do you anticipate Northwestern to participate in and ACO and or bundled payment demonstration projects? These are executive level decisions. How does a HHA or home health agency go about having an educated discussion with a large academic medical center to improve transitions in care by establishing a partnership between the two healthcare providers, home health and hospital?
Well, I think that's
a big question.
That's a good question. Smart person said that. Well, I think it starts with an understanding, and if you don't mind me saying that, I did notice that somebody put on the chat that there can be resistance between case management staff and relaying certain information needed for discharged clients. And to me, what that represents sort of ties into this question as well. The partnership is that I think we're just on the verge of such a culture shift that maybe we haven't been fully educated enough. People don't understand healthcare reform and how that will actually impact us in our daily practice. And I think that as those changes emerge, our practice has to evolve, and those changes will be essential. So, for example, what I anticipate Northwestern doing will be a series of educational opportunities for not only me as a manager and on a director level and our leadership to be addressing case management with how their roles will adjust. We have multiple projects going on right now addressing that very thing to define a future state of what our role will become, care facilitators, social workers, truly understanding how that culture shift needs to occur, how the home health agencies will be incorporated into that, what that partnership will be. And then I think it's really on us, leadership, to engage the home health liaisons, the different organizations that we work with frequently and have built good relationships, to bring them on board in this process and to ask the questions and to have them participate in various meetings and get their input about how we can utilize their programs better, to explain these are the initiatives that we are, proposing undertaking here at our organization. How can you meet our needs? How can we work together? And really relying on those relationships and building them further so that we can meet the needs going forward. I mean, I do see it as an absolute process, a culture shift, and something that will take time, but I think if done well and done, always staying in front of the communication, I think that it could work. I think that it could be very successful, that partnership. I mean, we rely on each other so much now. I think that I see a way that there are a lot of opportunities for sure coming.
Yeah, my 2 cents about it, after I initially stumbled trying to answer such a hard question. It's a hard question because how ACOs are actually going to look remains to be totally played out. But I think as I think about it, the objective of the ACO system is to incentivize a high quality outcome, and so thinking of it from the home care perspective, I think you can anticipate that the discharging institutions are going to be operating under an incentive system that really they want to know who the best home care providers are, and they're going to look for data that supports that, because they now have a stake in those post-discharge activities that they didn't have before, and so I think actually if I remember the question correctly, the question was more about smaller hospitals and associating with larger academic centers. You know, to whatever extent that same paradigm can be shifted to that relationship, I don't think it shifts very easily. But I do think that's, you know, that sort of shared fate or shared value, shared outcome is going to be what drives relationships, and you know, that and geography will lead to whatever networks end up forming.
Mm-hmm.
Our next question starts with the comment, we are a community-based hospital system with a related home health agency. We have a large staff of care coordination and discharge planners that include social workers and nurse case managers. We're considering a liaison program that would generally be set up as all referrals for any home health would be transitioned to the responsibility of a liaison who structurally would be under the supervision of the home care agency. Our objective would be to improve the quality of the transition for the patient and the clinician. Can you speak to the organizational structure of agencies that utilize a liaison and some best modeling to ensure accurate communication and making sure that all patients do not fall through the cracks? Also to the pros and cons of the use of a liaison.
Another great question and big. Okay, so sure, there are so that kind of goes back to what I was saying early on with sort of a triad approach. What I hear you saying is that in that example, you would have your social worker, your nurse coordinator, and now this sort of third piece, this triangular structure, and that individual is the liaison. And the cons, of course, are always slipping through the cracks, the communication, a lot of people involved, who's communicating to the patient, is there one point of contact, how do you decrease fragmentation of care? And I do believe that kind of that triangle approach, the triad, it can be successful. It really relies on, I think, the willingness of a strong leader to be the point person for the communication back and forth to the family. I think that when we get into lack of clarity of whose role is what, so I think to have very clearly defined roles and responsibilities first and foremost is essential. Who then communicates the overall plan of care to the patient? And we always have to keep in mind it has to be a patient-centric approach. So we can have a certain process, but if it's a major patient dissatisfier, of course, we don't want that. So perhaps if the liaison at some point that becomes that liaison's role and responsibility to actually interface with the patient and or family, then I think it has to be clearly defined how much of the care coordination planning will that person be responsible for communicating. And then, that liaison piece, it's about huddling in the morning with your other two disciplines, with your other two professionals, the social worker and the nurse. It's about working as a team, saying, let's lay out for the day what patients we're going to see, what needs to be accomplished. Perhaps there's a designated huddle time again going more towards the end of the day to now regroup and state, now this is what we have accomplished. These are the things still pending. These are the things that are going to be complications or problems. And all of that being tied in together, I think, to that care coordinator. And it could vary, of course. I mean, I'm just giving one example of how I think that sort of this triad approach could be successful by incorporating a liaison, which I think is a fantastic idea. If that liaison can represent the voice of the home health side, I think that's incredibly valuable information. I think that's something innovative and very smart, and the way that we're headed anyway. So to get down the process I think is the key.
Our next question from Ellen asks, how do you think a copay for home health will affect hospital admissions and readmissions?
Whoa, that's a great question. It's interesting to think about. You know, I guess I'll speak in general terms. When copays have been tried in other parts of healthcare, they decrease utilization, and you know, it depends on who's paying the copay and what it's set at. But I guess you know the
Okay, moving on to the next question. We ask, in a frontier-type home health agency with ice and snow during the winter, it makes it very difficult for the homebound patient to see a primary care physician every 30 days. It is likely that our physicians will be reluctant to use home care due to this face-to-face requirement. She adds that most of our patients are hospitalized 2 to 3 hours away or more, so coordination is even more difficult. Telehealth was attempted a couple of years ago, but due to difficulties with internet in the home, it makes it not very likely. Any thoughts about these issues? And thank you so much for a valuable presentation.
Well, thank you. That's a very nice compliment. Yeah, that's a technology question. Luke, are you there? I think Luke got disconnected. Yeah. That is incredibly challenging, first of all. I definitely want to validate that. I think that if the telehealth equipment isn't, you know, with the lack of internet services in various homes, which is understandable, you know, I wonder if there is a way for the home health agency, I don't know, to bill it through the outpatient services, through the primary care physician. How can we link up with that practice in order to ensure that they are getting what they need in the home, if it seems infeasible, that they will be able to return within a 30-day time frame to the physician's office? There are going to be incentives and de-incentives for everybody involved to ensure that those sort of, you know, innovative approaches to the care in the home will be taken. So I think I would look to a partnership like that in the future. It's challenging to think of at the moment, but certainly as we evolve, I know those are some of the ways we'll have to be looking at things.
Our next question asks, does Northwestern Hospital have after-hours help for discharged patients as an ER alternative?
Okay, say it one more time. I'm sorry.
That's okay. To repeat, does Northwestern Hospital have after-hours help for discharged patients as an ER alternative?
So what we have is we have a social worker on call 24 hours a day. And so while that individual may not be physically present in the hospital, if any patient in the community, if anyone calls into our main line of the hospital, they can, and they request to speak to somebody, they can be transferred through our answering service to someone who is on call. So there's always a 24-hour, 7-day-a-week support available, and to provide linkage to resources, problem solving, a follow-up plan for the next day. And we also do have our care facilitators, who are nurse counterparts to the social workers, who are on call as well if in the event the phone call comes in, the request comes in that is clinical in nature, that requires a nurse's input.
Next question asks, where do you see home care organizations fitting into the ACO model? Do you believe they will be attached to the medical homes or the hospitals?
Hey, this is Luke again. I'm sorry, I got disconnected. Jessica, do you want to answer that, or I'm happy to?
Yeah, no, go right ahead.
I think it remains to be seen. I think that they, at least in the early going, there's a lot of independent home care companies out there, and they'll continue to operate as independent businesses as long as there's a business model that works for that. So, I think they will be independent, but as I said earlier, I think that we will all be subject to the performance-based contracting and performance-based reimbursement, which isn't to say that doesn't happen now in home care. I think that there is that kind of evaluation and quality is rewarded, but I think the same trend that's happening for hospital public reporting of outcomes, readmission outcomes included, we can expect that to happen in other parts of the industry as well.
Our next question comes from Karen, who asks, can you address the role of hospitalists in the process and the reality that some patients are discharged without a primary care provider?
Rob, do you want to?
Yeah, that's, I mean.
Rob and I are both hospitalists, so we know this issue well.
Yeah, no, that certainly is a major challenge. In terms of getting patients plugged into primary care. How do we?
And our next question comes in the form of a comment that this participant, Jerry, would like to hear from you all. She says, it sounds like the new health care reform will push all of us to think about working together more closely. Jerry would like to thank all of you for this presentation and state that it sounds like Northwestern certainly is a leader in practice changes, and see what your thoughts are on this.
Well, I don't know anyone at Northwestern named Jerry, but if I had to guess.
Thanks, Jerry. Thank you very much.
I don't know. I think like all places, we're trying, and it's nice to finally be looking down the road into an environment where all the incentives are aligned to generate quality.
That wraps up our Q&A. I'm going to toss things back to the HHQI Medical Director, Dr. David Winter, for today's closing remarks. Dave?
Thanks, Shannon. Before we sort of close, Cynthia Pammon, who's our government task leader, I know would love to make a couple of comments before we end the presentation. Cynthia.
Hi, Dave. Can you hear me okay?
Yes.
Okay. Hi, everyone. I just wanted to thank all the presenters. It was wonderful. This was probably one of the best webinars that I've listened in on. And certainly appreciate all of the listeners and the questions. They were excellent. And if you have any additional questions that you'd like to ask later on, I believe WVMI have a methodology for you to do that later on. But again, on behalf of the leadership at the Centers for Medicare and Medicaid Services, I want to thank you all for your participation. And I look forward to hearing more from you. We have to bring you all back.
We'd love to.
Yeah, thank you very much
for this opportunity.
Yes. Thanks very much, Cynthia, for those remarks. And again, I echo those sentiments from the rest of the home health quality improvement team, as well as the participants on the call. For Luke, Rob, and Jessica, this was a great presentation. We really greatly appreciate your thoughts and ideas, and we do look forward to some future opportunities together to be able to share sort of some of the great things that you're continuing to work through. So with that, we'll close for the day, but just to remind everyone that today's presentation is going to be archived. We will probably by late tomorrow afternoon, Friday afternoon, or certainly no later than Monday, have the archived portion of the presentation as well as the PowerPoint slides available for any of your colleagues that were unable to participate on the call today. Again, we're working on our next webinar, and as soon as we have things finalized, you'll hear more about that on our website, www.homehealthquality.org. And with that, we want to thank you again for all of your participation, and on behalf of the National Home Health Quality Improvement Campaign team, we hope you have a great rest of your day. Thanks again for your participation.
Thanks very much.
Great. Thank you.
Take care.